Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Oatsko America Pharmaceutical Inc. and Lundbeck.
I'm Paul Rosenberg. I'm a professor of psychiatry and behavioral sciences at the Johns Hopkins University School of Medicine in Baltimore, Maryland. I'd like to welcome you to this program titled Back to Basics in Agitation Associated with Alzheimer's Disease, Mechanisms and Implications for Treatment. In this lecture, I'm going to discuss what agitation in Alzheimer's is and why it's important, what we know about the pathophysiology of agitation in Alzheimer's disease. We have intriguing and scattered knowledge, not a firm model yet. And I'm going to talk about pharmacologic treatment options for agitation in Alzheimer's, including mechanisms of action, efficacy, and safety data. Let's start with the definition of agitation in Alzheimer's and why it's important. I've been fortunate enough to be part of a consensus group that has revised these criteria for the International Psychogeriatric Association. And there are 4 criteria. First, the patient has to have a dementia or pre-dementia syndrome, such as Alzheimer's dementia or mild cognitive impairment due to Alzheimer's. Second, there are 3 areas, and they've got to have behaviors in at least one of them. The first one is excessive motor activity. This can be pacing, rocking, pointing, or other physical repetitive activities. It can be verbal aggression. That can include shouting, cursing, and so on. And it can include physical aggression. So we've got motor activity, verbal, and physical aggression. And you have to have behaviors that cause emotional distress in one of these areas for at least 2 weeks. So there's a 2-week minimum. These behaviors have to be associated with some distress or disability. In other words, they have to be affecting interpersonal relationships, other aspects of social functioning, and daily activities. And they can't be explained solely by other psychiatric disorders, for example, pre-existing bipolar disorder or schizophrenia. Agitation is the 3rd most common neuropsychiatric symptom among cognitive disorders. Prevalence is up to 75% and even more frequent in nursing home populations at 80%. In Alzheimer's, similar numbers, 76% among people with Alzheimer's dementia and 60% among patients with MCI due to Alzheimer's disease. It can be present at any stage of disease, but it's more common with dementia of increasing severity. There's a lot of burden, huge impact on the patient, a poorer quality of life, increased risk of institutionalization, excessive morbidity and hospitalization, more rapid disease progression. There's no question that agitation impacts the care partner. It's associated with more stress, more depression, less income. And there's a lot of expense on the healthcare system, probably doubles the cost of caring for patients with Alzheimer's disease from about $9,000 to about $20,000 a year. So what do we know about the pathophysiology? And as I said before, it's intriguing. It's a little scattered, and I don't think there's a single model that you can simply put up and say, here's what causes agitation. But here are some ideas. The first thing is it tends to be multifactorial. It may be due to the underlying pathology of Alzheimer's. It may be due to delirium. It can be due to pain. And actually, there's a number of studies showing the association of agitation with pain. They just showed this in a large Swedish cohort. Medications may make people agitated, particularly if they cause delirium. Patients, of course, may be agitated because they have emotional or psychological distress, and there may be changes in the environment or unmet needs. We often see on structural imaging we'll see reduced volumes in selected brain areas associated with agitation and Alzheimer's. These include smaller volumes in frontal cortex, anterior cingulate, posterior cingulate, insula, amygdala, and hippocampus. If you think about it, it's kind of a mix of regions that we customarily associate with Alzheimer's, such as posterior cingulate and hippocampus, other regions that are more involved with emotional reaction and processing, such as the insula and amygdala. And in general, decreased brain volumes in these areas have been associated with agitation in Alzheimer's. And these overlap brain regions associated, as I said, with core Alzheimer's pathology, with emotional regulation, and with the salience, that's the importance of events. Agitation is also associated with increased tau deposition and phospho-tau deposition in the frontal cortex. And looking at people with mild behavioral impairment, which is a codification of psychiatric symptoms in Alzheimer's, we find that MBI is associated with amyloid deposition, particularly in the neocortex and then in the striatum. So there are associations with both tau and amyloid deposition. There have been some intriguing changes observed in brain functional connectivity. There are sort of two basic syndromes. One is agitation, also called behavioral. One is anxiety. And this involves connectivity with both the somatomotor and default mode networks, which makes a lot of sense in agitation. Neurotransmitters are also likely to be important. We don't know much about what amyloid beta does or if it has a physiologic function, but what we do know, particularly in preclinical studies, is that amyloid beta seems to be involved with regulating synaptic plasticity, with memory, and with neurotransmitter release from presynaptic terminals. So there's an interaction between amyloid beta and several neurotransmitter systems, and amyloid beta may be involved with maintaining the balance between them. And as more amyloid beta is deposited, we likely are seeing changes in synaptic function. And this is very possibly where changes in circuits are occurring. So amyloid beta may change synaptic function and change the strength, really, of networks in the brain. There's been some more basic science work done. Lower cholinergic markers are associated with aggression, as are lower serotonin and serotonin metabolites. Neurofibrillary tangles in the nucleus basalis of Meinert have cholinergic projections to many regions of the brain associated with agitation. And Alzheimer's progressions associated with loss of serotonergic neurons in the raphe and in their cortical projections, particularly frontal cortex and amygdala. So there's a lot of connections, sort of tantalizing connections between neurotransmitter changes, particularly lower acetylcholine and lower serotonin, and potential mechanisms of agitation. The serotonin system is very complicated, and I will not try to summarize it here. But suffice it to say that we certainly see decreased serotonergic innervation, serotonic neurotransmission in Alzheimer's and in cognitive impairment. And to some extent, it's associated with agitation. We see reduced 5-HT receptor 1A in the medial cortex associated with aggression, and other serotonin receptors modulate aggressive behavior. There's a complex interplay between the many serotonin receptors and Alzheimer's pathology, and decreased serotonergic neurotransmission may be associated both with Alzheimer's and with agitation. And the hypothesis is that agitation may be related to disruptions in cholinergic and serotonergic pathways. Let me talk about non-pharmacologic interventions and assessment for a moment. There's a number of popular algorithms for assessment and interventions: DICE, the GSA decision tree, and the IPA management algorithm. And they all list non-pharmacologic strategies as the first line in managing agitation. And you should only consider medications if these prove inadequate. And even then, you are probably adding pharmacologic therapies to non-pharmacologic. One thing about the DICE approach, it's meant to be a multimodal analysis of behavioral problems. One of the most important things is to rule out delirium, because Agitation and Alzheimer's and delirium are separate entities. They may look alike, and you have to look carefully at the clinical differences, particularly the time course and the repetitive nature of it. You wouldn't want to be treating the UTI with a drug for agitation. You'd probably want to be treating the UTI with an antibiotic, just for an example. So diagnosing the delirium and diagnosing the cause of delirium is crucial in management. Other things we do in non-pharmacologic interventions, we educate the care partner as to what agitation is and what some of the approaches are. We try to enhance communication and problem solving. There may be environmental changes. The house may be too warm, too cold, too light, too dark, too stimulating, too boring. Having activities planned, particularly a schedule, is something that we really advise. Trying to simplify tasks and break them down into individual subtasks. And of course, we encourage the care partner to take care of themselves and participate in support groups. There's increasing evidence for the efficacy of selected behavioral interventions. Since I play music as a hobby, I'm particularly interested that music therapy has a particularly good track record. Patients can often process music in their brain when they can't process language very well. And we often see people who can sing or play instruments and participate in those activities when it's much harder to participate in pure verbal activities. Other potential treatments, therapeutic touch and massage. And there's some evidence for aromatherapy. Controversial because there's studies for and against, but it's worth thinking about. Now let's look at pharmacotherapies for agitation and Alzheimer's. We start with brexpiprazole. It was approved in May 2023. It is an antagonist at the serotonin 2 receptor, as well as a number of other serotonin receptors, and a partial agonist at the serotonin 1A and dopamine D2 and D3 receptors. Also has affinity for histaminergic and muscarinic receptors. The point with the receptorology is brexpiprazole and a number of other newer antipsychotics are a bit different from older ones in that they don't have much dopamine D2 antagonism, so they're much less likely to cause extrapyramidal symptoms, and they may be less likely to cause tardive dyskinesia. I think the crucial mechanism here is the serotonin 2A antagonism. And brexpiprazole, it sounds a lot like aripiprazole. It's a similar compound. It's not actually a metabolite, but it is quite similar pharmacologically. In terms of clinical trials, there were 2 phase 3 12-week trials published in 2020, and 2 milligrams a day of brexpiprazole was associated with a decrease in the Cohen-Mansfield Agitation Inventory score and with improvement in the clinical global impression score. So the Cohen-Mansfield is one of several scales we use to measure agitation. It's particularly useful for severe dementia and for nursing home populations, but can be used in any population. The clinical global impression is a clinician's basically anchored judgment of how the patient is doing. Keep in mind the clinician is blinded as to whether the patient is on drug or placebo. Common adverse events were headache, insomnia, somnolence, dizziness, and urinary tract infection. Most importantly, there's a 12-week phase 3 study published last year, N was 345. They saw a significantly greater improvement in the Cohen-Mansfield score, which went down from around 80 to around 75 in the group on drug, and considerably less in the group on placebo. The effect size of 0.35 is considered moderate, a little on the low side, but still a significant effect size with a p of 0.003. They saw a very similar effect size and a statistical significance for improvement in the clinical global impression related to agitation. The only adverse event that had a significant incidence was headache. And in general, the results of this trial suggest that it's most likely to benefit patients who have both agitation and aggression. This is an FDA-approved drug. It can be a bit of a task to get insurance approval since it is a brand name drug, and it can be quite effective. It's important to note that brexpiprazole is an antipsychotic. The FDA has a box warning about mortality on brexpiprazole's use in dementia, as it does with all antipsychotics in dementia. In general, we've not been able to study the effect size of mortality. We've not been able to really study the amount of increase in mortality risk, but it seems to be associated with most antipsychotics. And we're really not sure if it's cardiac or cerebrovascular mortality. For these reasons, we need to inform patients and families of this risk, and we need to get their informed consent. In my clinic, I do this verbally and not in writing. Other people do it in writing. Personally, I think the magnitude of the risk isn't very large. For instance, in a 3-month study in dementia, antipsychotics are associated with about a 3.5% mortality. That's quite a bit for 3 months. Placebo, 2.3% mortality. Also quite a bit for 3 months. So it's 3.5 versus 2.3% in a 3-month trial. What we're really lacking is rigorous data taking this out to a year, 5 years, 10 years. That's because knowing this risk, we've not been able to do placebo-controlled trials in this area for the most part. So I think clinicians have to take this caution and not use antipsychotics lightly due to this mortality risk. And most importantly, inform families, who are usually the decision makers at this point. Cholinesterase inhibitors actually can have an effect on many neuropsychiatric symptoms, agitation and apathy, among others. In general, you need to go to the highest dose. For instance, a meta-analysis that included about 20 studies found a behavioral benefit only with the high dose donepezil, 10 milligrams a day. You'd expect that. And with the highest dose of galantamine, 24 milligrams a day. I find the cholinesterase inhibitors help somewhat with behavioral symptoms, but they're not very potent. And I consider them, if I'm using medications, I consider them a useful part of a cocktail, but probably not the basic treatment. But the effects observed with cholinesterase inhibitors are not specific to agitation or aggression. There are similar data for apathy, and they're probably not good for acute or for the most severe agitation. Antidepressants, there's been a lot of work done with SSRIs, selective serotonin reuptake inhibitors, and I was part of a trial of the drug citalopram, and citalopram significantly reduced agitation over a 9-week period on a different scale we use called the neurobehavioral rating scale, showed a significant decline, and we also saw increased response on a clinical global impression. Now, the citalopram results, so citalopram joins the armamentarium of drugs that may reduce agitation in Alzheimer's. There were some caveats. We were using a dose of 30 milligrams a day of citalopram, which at that time had no particular worries about safety. In the middle of the study, the FDA came out with a warning about QT interval prolongation with doses of citalopram above 20. And we indeed found a modest increase in QT intervals. So I think the clinician is left with a little bit of a quandary. Do you give 30 milligrams, which was effective, but maybe had increased QT intervals? Or do you give 20 milligrams, which the FDA is supportive in terms of safety, but may not be as effective for agitation? We actually found in that study that the benefits were associated with the S isomer, which is known as escitalopram, whereas the cardiac effects with the R enantiomer, which didn't have much effect on an outcome. So we have recently completed a trial with escitalopram. However, it was underpowered. We did not achieve our recruitment goals, largely due to the pandemic, which has had a huge effect on recruitment throughout the Alzheimer's spectrum. And so I regard the data as a bit inconclusive. They went in the right direction, but were not statistically significant. A couple of unique mechanisms of action. Dextromethorphan-bupropion combination, known at the moment as AXS-05. It's got 2 drugs in it. One is dextromethorphan. It's an NMDA receptor antagonist and can alter the tone NMDA receptor neurotransmission. Also a sigma-1 receptor agonist, which additionally modulates glutamate signaling. And so the essential drug here is dextromethorphan, but if you give it orally, you can't achieve any decent brain levels. So they added bupropion, a widely used antidepressant, which is also a cytochrome P2D6 inhibitor and increases the dextromethorphan concentrations greatly in the plasma. It's also a weak inhibitor of norepinephrine and dopamine uptake. This combination of dextromethorphan and bupropion has been approved for major depression, and it's also been studied pretty extensively for agitation and Alzheimer's. There have been results recently released of the Accord trial. Accord trial is very interesting because they did an open label response study. I think it was 6 weeks. They found in the open label period that they had a clinical response in 80% of the patients. But then they did a double blind discontinuation. This is really helpful for clinicians because it can give you an idea whether patients need to stay on a drug longer term. So of the patients that responded in the open label, half were randomized to placebo, the other half to continue on AXS-05. And the risk of relapse was a lot lower for the patients on drug. It's pretty safe and well tolerated, and there was no evidence of cognitive decline or sedation. So this is a drug that I think may advance to getting an FDA indication in the reasonably near future. There have been other attempts with dextromethorphan compounds. One of them is combined with quinidine. Once again, quinidine is being used to basically inhibit catabolism of dextromethorphan and increase blood levels and therefore increase brain levels. It's actually been used in incredibly tiny doses, like 5 or 10 milligrams is a typical dose. And there's been a number of drugs attempting to do this. This one, AVP 786, happens to be a drug that is deuterated dextromethorphan. This combination is FDA approved for treating pseudobulbar affect, which is really a different problem than agitation. And the company's been studying it for agitation. They had some promising phase 2 trials. However, they had null results in their phase 3 trial known as Triad 1. That was announced pretty recently. My understanding is that the company has dropped this drug development program. People are starting to use THC, and my colleague Brent Forrester and I have recently completed a double-blind study of THC for agitation and Alzheimer's. We're not ready to present the results in a peer-reviewed journal yet, since we've only had them for about a month, but the results were quite positive, and I think you'll be seeing more in this direction. There are reasons why the endocannabinoid system might be helpful in Alzheimer's. CB1 regulates neurotransmitter release. CB2 probably is involved with modulating anxiety. And so to some extent, these may be anxiolytics. So to summarize, the etiology of agitation in Alzheimer's is multifactorial. There are neuroanatomical alterations associated with agitation in Alzheimer's, and these overlap brain regions associated with core Alzheimer's pathology, with emotional regulation, and with salience, the importance of events. And the pathophysiology of Alzheimer's also includes disruptions to several neurotransmitter systems, particularly cholinergic and serotonergic pathways, and particularly in the frontal and temporal cortex. There are approved and emerging pharmacotherapies that target neurotransmitter systems and receptors. There is one FDA-approved therapy, brexpiprazole, which is partial agonist activity at 5-HT1A and dopamine D2 and D3, antagonist activity at 5-HT2A, as well as some other serotonin receptors and alpha-adrenergic receptors. So there's one FDA-approved drug and likely others on the way. Particularly pay attention to that dextromethorphan bupropion combination, AXS-05, which I think will be going places. Agents used off-label include cholinesterase inhibitors and SSRIs such as citalopram. I'd like to thank you very much for participating in this activity and allowing me to take up some of your time today. Please continue on to answer the questions that follow and to complete the evaluation.